So what do we do? Get partners like Cairo. Cairo stepped up. Did you know that the Japanese community actually has a high prevalence rate of diabetes? I didn't know that. Go, really? Well, they're leading off. They're leading in their community. They're recruiting people. They're getting them trained to lead this program. Volunteers can lead this program. They're making a big difference, and it's really working well now. They've been doing the general program. Now they're moving into the diabetes-specific, same program. So, and Stanford has taken this many places. So, while in America we're doing it in 47 states now under the Administration on Aging, it's actually in 22 countries. So, very, very powerful to pick something like this. You could pick anything, you know, whatever, as long as you have a focus and you're like, they call me water on a rock. Drip, drip, drip. I just keep going. I'm not quoted very often, but if I am, it's usually for my favorite phrase, which is, no just means it's a much longer discussion than we were planning on. Respectfully, of course. You have to listen and see what the objections are, but persistence is required for the kinds of individual changes. If somebody says something to you once, that's nice. It might even get your attention. You might even come out of here, if I was really lucky, you'd go out going, wow, that's interesting. Maybe I should do something about that. You'd have to hear about it quite a bit more, you know. They don't sell you Coca-Cola with one ad. You know, it just doesn't happen. So, how do we change behaviors? Put up a road sign here. Well, we probably do have to put up some road signs. You yourselves probably know about behavior change and how it works. Prochaska kind of developed this. People are at various points of readiness for change. So one of the important things to do is to invest your energy in people who really want to change. You have met the people who are not interested in changing. Not going to change. No, thank you. And so, you know, that's up to them. Just give them information because they're in that pre-contemplation stage. They're not at contemplation. They're pre-contemplation, which is no, or, huh? What are you talking about? Irrelevant to me, not of interest. But then sometimes people have been thinking about things. Like you go, you know, I really should X, Y, or Z. Begin exercising more, get out with my friends more, call friends that I'm losing touch with, whatever it might be. So then you're in the contemplation stage of readiness for change. Then people, they really think, okay, I'm going to do it. So they start trying to say, okay, I'm going to join a health club. I'm going to buy an elliptical. I'm going to get a walking club on my block. I'm going to buy a dog who will walk me. That works well for me. Having a dog does get you walking. It's very good. Then there's the action stage where people are really doing it. And then, you know, once you get a behavior in place, you have to keep it going. So there's some work that's been done. It's mainly started around substance abuse and alcohol dependency called motivational interviewing. You know about motivational interviewing? And that led to some work that's being done around brief negotiation, because, you know, how long do we have anyway, right? Say, come on, June, you don't have too much more time. Okay. So anytime you're talking with someone, it can't be like forever. So brief negotiation is designed to go in, assess, set goals, and decide, is somebody really interested in changing something that would improve the quality of life and their health in 15 minutes. So it's very quick. It's a kind of a very brief cognitive counseling style. That's based on these stages of change. It's very respectful. It's about asking permission. Are people even willing to discuss the possibility of a change with you? And we have a program, it's physical activity program for people who are very, very frail and may also be low income. So they don't have to go to the gym. They're not going out in spandex in public. They do not wish to do that. They don't have money for videos and cable, and they don't have money for equipment. So these are very simple things. So we use this, and we went out with people, you know, 70, 80, 85 years old, about 1,000 of them, and you think, and they're all very sedentary and very frail and very low income. You know, they were really kind of delighted that somebody thought they actually could do something about their health. We thought maybe they think we were nuts, but we got a lot of uptake. As long as it's safe, you've checked it out. So, you know, you can ask people, are they ready? And then there's a whole structure for this process. You can give them the ruler, you know, green for green light, red for never, and all across. And you ask people, if you have a change you'd like to engage in, how ready are you to do it? And this is part of the Stanford model, the Healthier Living program as well. They don't use the ruler, but they do assess readiness. So people can say, I'm at 10, I'm already, you know, I just bought a new piece of equipment, I got a personal trainer, I'm going to the gym, I bought a new dog, whatever it is. Cute dog, I should have a dog slide, right? That would be improve this. But then if they're answering lower, then you can discuss with them why. What's in the way, what's stopping them, and how might they proceed? What would interest them if they want to make a change? So brief negotiation is very powerful. Now, changing systems is in some ways the same, in some ways different, of course. And when you're changing organizations and systems of care and ways that we have of conducting these big spheres of our society, like healthcare, education, you'll have to have a business case. You know, you have to get people. Well, here, this is university sponsored. Now, this is a very inspiring university, of course. In most universities, changing curriculum, woo, you know, kind of tough. Getting someone to change something they've mastered and put a lot of work into. Same thing with healthcare. I mean, I guess it'd be like if you went to a musician. You're going to go to Itzhak Perlman and say, you know, I'd like you to play it a little differently. Itzhak says, hey, you know, I've got this down. So anytime you're bringing an opportunity for improvement, and change is usually designed to be favorable, you're insulting the status quo. And you're asking for extra work. You're making some vision that's hopefully inspiring enough that the first group of people will step up. You're going to have your early adopters, Cairo, Escatan, you know, people that step up. Connie Corley, always an early adopter. Yeah, that sounds great. Let's do it. And those people step up, and you might as well work with them. They're high on the readiness scale. Then you have some that are in the middle that'll come along there a little bit, you know, show me. So when they see it's working, they can kind of manage it. And then you have kind of the hard to change who are going to take quite a lot longer. But you can see, like with quitting smoking, you see these things progress over time and work to tip. So changing healthcare is like that. Changing food for kids in schools is like that. You've been watching that debate. Putting physical activity back in the lives of children in a safe way. Getting physical activity in the lives of adults. There's a movement here. There's a program, you've probably seen it. They're trying to take out to the workforce and say, if your meeting is more than an hour, take a recess, stand in place, and have some movements right there in the meeting room, in the workplace. Go, whoa, will people be able to tolerate that? Will that be too embarrassing? So changing the way healthcare is practiced, whew, that's really serious. Moving from healthcare to health promotion, focusing on the person instead of the presenting problem, very exciting piece of work, but complex, and it'll probably take that whole 17 years. But we've made a lot of progress. Now, we have a lot of people who are criticizing the Affordable Care Act, the health reform. Well, fine, but we need to change it one way or another. I mean, it's just clear. If you just need nothing else, money can make change. And so we have to change the way we pay for things. But, you know, we talked something about it takes a village, but it also takes a set of community systems to rise to a change. So as we're working to bring some of this healthier living notion out to people, we're trying to look at who can we work with. So across the state, we can work with the Low Income Senior Housing Association, Aging Services. in a community, we can work with public health, we can work with hospitals, we can work with doctor groups, community colleges, fielding, faith-based organizations, the mental health sector, very, very important, senior centers, parks and recreation, you name it. It's probably others you can think of that are very, very important educational systems beyond the community college, for sure. We had them in there for a specific reason, but trying to look for the local champion, because, you know, that's the other thing change takes. It needs someone who says, this is important. I want to get this done. I'm going to really step up. I'm going to try to get some folks that also think it's important, and we're going to work together. So we see the leadership. We see Lynette step up at Eschaton. Lynette knew this stuff, and she gains partnerships. They grow it inside their system. They grow it inside their community. K-Rose, same thing. So you look where you can find the early adopters in any given sector and see if they can bring up enough visible change that's exciting and positive that others look and go, oh, that looks kind of good. And then they're making their own change, because just like in brief negotiation, organizations have to decide to change, either because they have to or because they want to. Want to is nice, but sometimes, like in something as complex as our healthcare system, that's really impacting, you know, it's one of our biggest industries. It has all these specific players in it. There's so much money in our society tied up in it. It's not an easy baby to mess with. So we want to look, and in the nation we have the Affordable Care Act. In California we have the 1115 waiver, which means we're going to change across the board the way we deal with Medicaid, people in Medicaid. So that's a big opportunity. So they're doing dramatic things to try to do something America noticed. If you can't get health care, it's dangerous. Now, we can all go along for a period of time, we don't need it. But at some point when we need it, it's better to get it sooner than later. Now, we have a tendency in our old health system to wait until you're the wreck of the Hespers. Okay, you can't have too much, don't have this, don't have that. Then, you know, when you're at death's door, say, oh, put him in the ICU, call 911, run him through the ER, let's just give them everything, don't let them die. You go, I would rather invest in quality of life and alternatives to 911. For instance, we've done a lot of work in palliative care at home. What do you do during the last year of life to make it good? Because, you know, it's still a time of great meaning, and if you're lucky enough to get notice, it's kind of good because you can really realize, okay, what's on my bucket list? Let's get it done. You know, this is important. And 25% of the Medicare dollars spent in the last year of life. So it's a huge societal investment. But we found with giving people choices, meaning more than one discussion, more than handing them an advance directive, but having discussions more than once, having really good information from their